Ladies and gentlemen, my esteemed colleagues all over the country, this is Dr. Soumitra Kumar from Kolkata. I'm here with the highlights of ESH 2023 Day 2. I'm going to present before you the important presentations that were made on Day 2 of ESH 2023. So the first paper that I'm going to present before you is this one. Salt restriction combined with renin-angiotensin-aldosterone system blockade is a potent antihypertensive strategy in patients with primary aldosteronism. Now we have known that salt restriction works very well for essential hypertension, but patients with PA, that is primary aldosteronism, the most common endocrine cause of arterial hypertension, are believed to be exquisitely salt sensitive, that is, they respond particularly well to salt restriction. However, surprisingly, little efforts have been made to determine the precise impact of salt restriction in patients with primary aldosteronism. So the researchers in this paper set out to implement a moderate salt restriction in patients with PA to assess its impact on blood pressure and secondary health outcomes. So the investigators used a nutritional education and continuous self-monitoring via a smartphone app to reduce salt intake in 41 patients with PA for a time span of 12 weeks. All patients were on mineralocorticoid receptor antagonist therapy, that is MRA therapy, and had stable blood pressure. Patients were monitored every 4 weeks with blood pressure and urine sampling and detailed blood work at weeks 0 and 12. Mental well-being was addressed by a validated scoring system. So these were the results. So you see the salt intake by the end of 12 weeks have come down from 9.1 to 5.2, blood pressure from 130 by 84 to 120 by 81, body weight from 83.2 kgs to 81.8 kgs, and even the depression improved from PHQD score of 5.3 came down to 4.3. So the results were evident. There was a decrease in blood pressure, decrease in salt intake, significant loss of body weight, improvement in the status of depression, and multivariate regression analysis revealed that cumulative intake of drugs targeting the renin-angiotensin-aldosterone system was an independent predictor of blood pressure reduction. So conclusion, salt restriction is an effective treatment in patients with primary aldosteronism. Patient empowerment by education and self-monitoring promotes salt restriction. Effects are facilitated by concomitant RAS blockade. Salt restriction, despite being moderate, also improves mental well-being. Now the second paper is the DASH diet versus Mediterranean diet on a salt restriction background in adults with high normal blood pressure or grade 1 hypertension, a randomized controlled trial. This one was from Greece by a group of investigators. Now, as you know, for this group, high normal blood pressure and grade 1 hypertension, generally one recommends non-pharmacological measures. So in this context, this trial was very relevant. Apart from salt restriction, which applied to all the groups, that is the control group, the DASH diet group, and the Mediterranean group. But basically, what was the investigators trying to see? I mean, beyond salt restriction, which was superior, the DASH diet or the Mediterranean diet? The researchers randomly assigned never drug-treated individuals to a control group, a salt restriction group, a DASH diet with salt restriction group, and a med diet with salt restriction group. The primary outcome was the attained of systolic blood pressure difference among the randomized arms at the end of the study. A total of 240 patients were enrolled, while 204 completed the study, 85%. According to intention to treat analysis, compared to the control group, office and 24-hour ambulatory systolic and diastolic BP were reduced in all intervention groups, that is the salt restriction group alone, and the DASH diet plus salt restriction and the Mediterranean salt restriction. As you can see that there was better blood pressure lowering in the Mediterranean diet group. The DASH diet group and Mediterranean diet group did not differ concerning the office diastolic blood pressure and the 24-hour ambulatory systolic and diastolic blood pressure. However, both diets were more efficient in blood pressure lowering compared to the salt restriction group alone. So conclusion, on a background of salt restriction, the med diet was superior in office systolic blood pressure lowering, but DASH and MED diet reduced blood pressure to an extent higher than salt restriction alone. The third paper presented on the day 2 was this one. Plasma metabolomic profiling predicts aortic stiffness and risk of incident cardiovascular disease and mortality after 16 years of follow-up in the general population. The researchers aim to investigate the plasma metabolomic profile in aortic stiffness, incident cardiovascular disease and mortality in the general population. So there were various metabolic profiles that were being studied, and the study characteristics are displayed in the subsequent table. Aortic stiffness was positively associated with following metabolites: long-chain acylcarnitines, dimethyl 1-urinovaleric acid, glutamate, and cysteine, while serine was negatively associated with aortic stiffness. The plasma metabolome predicted aortic stiffness in the validation cohort with good accuracy, and metabolite predicted aortic stiffness was significantly correlated with age and sex. And during the average follow-up of 60 years, aortic stiffness predicted by baseline metabolites were associated with increased risk of incident coronary artery disease, incident stroke, cardiovascular mortality, and all-cause mortality in the older population. So this is the table I was referring to. You can see the older population on the left and younger population on the right. And for the other variables which are a little different from the two groups, but one can clearly see that aortic stiffness was much higher as predicted in the older population, 10.5 plus minus 2.5 versus 7.5 plus minus 1.6. And these were the metabolites associated with aortic stiffness. Now you can see the ones positively associated, but serine, as I've already said, was negatively associated, and so was others like tryptophan and so on. But the major number of metabolites were positively associated. The leading amongst them were carnitine, cysteine, DMGB, and so on. And this was the scatter plot. You can see the ones that predicted are in the middle, and there was a large number of them which actually predicted the aortic stiffness, but then there were others which were either underestimated or overestimated. And the most important thing in the 16-year follow-up, it predicted all-cause mortality, cardiovascular mortality, coronary artery disease, and stroke. So aortic stiffness is an important predictor. And if we can study the metabolites that are related positively or negatively with aortic stiffness, that becomes a great thing in public health. That becomes of great public health value. So to conclude, for the first time, we show that aortic stiffness is predicted by altered metabolism of various metabolites. These metabolites precede aortic stiffness by several years and are also associated with increased cardiovascular risk factor burden and future risk of CAD, stroke, cardiovascular mortality, and all-cause mortality. Our results highlight the relevance of investigating the molecular pathways related to aortic stiffness. Further metabolomic studies are warranted, of course, to verify these findings in the population. So the next paper presented on day 2 of ESH was blood pressure and the various inflammatory markers like hsCRP, interleukin-6, and white blood cells in the community-dwelling older adults. So understanding this association in this population is particularly important in the context of increased prevalence of hypertension, as well as role of inflammatory response in age-related comorbidities. Now, the researchers examined the relationship of these markers that I have mentioned amongst older people aged more than 65 years, 3,500 plus of them, and 587 middle-aged, 57 plus minus 1 years old adults recruited as part of Poll Senior Health Survey. Now, the results are quite a busy slide. It's difficult to go into the details of this, but I'll just give you the conclusions. CRP and WBC, but not interleukin-6, are positively associated with high blood pressure in the population of community-dwelling older adults, independently of age, gender, and BMI. Results of our study may suggest an important role of inflammation in the pathogenesis of increased blood pressure, also in the older population. The next paper was comparative efficacy and acceptability of different antihypertensive drug classes for cardiovascular disease prevention a systematic review and network meta-analysis. So the European guidelines recommend combination therapy for most hypertensive patients, but direct comparisons between major drug class combinations are lacking. The aim of the investigators was to compare the efficacy and acceptability of different drug class combinations. So a systematic review and network meta-analysis was performed from the Cochrane collaboration. The investigators included all trials assessing any antihypertensive drug combination against another combination, single agent or placebo, with at least 1,000 patient years of follow-up in each treatment arm. Risk of bias was assessed using Cochrane collaborators, ROB-B2 tool, excluding trials at high risk of bias from the analysis. Odds ratio from individual trials were pooled using random effects network meta-analysis with composite MACE as the primary outcome for efficacy and treatment discontinuation as the primary outcome for acceptability. So overall, 85 trials with more than 4 lakh participants followed for an average of 4 years were included in the analysis. Mean age was 64 years and 41% were ladies. Overall, 15 different drug class combinations or placebo were included in the network. Direct comparison between combinations were sparse, and there were signs of inconsistency between direct and indirect comparisons, particularly for acceptability. The main results are presented in the next figure that I am going to present. Combinations using RAS inhibitors and CCBs appear to be the most effective in preventing MACE, followed by a combination of thiazide and potassium-sparing diuretics. And however, for acceptability, no combination differed significantly compared to placebo, although combination using ARB tended towards being more acceptable, and combinations including and angiotensin converting enzyme inhibitor trended towards being less acceptable compared to placebo. So here the results are pretty obvious. ARB CCB the best combination, followed by ACE inhibitor CCB, diuretics and potassium sparing diuretics, followed by ACE inhibitors diuretics, and surprisingly ARB diuretics fared the worst. And treatment discontinuation against was the least in ARB CCB and diuretic potassium sparing diuretics, and was the highest with ARB ACE inhibitor CCBs and ACE inhibitors plus diuretics. So overall, ARB plus CCB combination appeared to be the best combination. So in this first network meta-analysis of antihypertensive drug combinations, RAS inhibitors plus CCB appears most effective in preventing major cardiovascular events. Based on a more beneficial acceptability profile, combinations including ARB may be preferred over combinations including ACE inhibitors, although these findings should be interpreted with caution due to lack of direct comparisons. Now, the next trial was association between nocturnal variation in blood pressure and risk of acute ischemic stroke, a systematic review. BP is a dynamic parameter characterized by fluctuations during 24-hour period. Variability of blood pressure has been associated with severe risk and occurrence of acute ischemic stroke. Circadian variation in BP during night shows some basic patterns. The purpose of this study is to correlate deviations from baseline patterns of circadian BP variation with the risk of acute ischemic stroke to select the optimal therapeutic intervention. Design: the investigators systematically reviewed the literature from 1990 to 2022 through electronic medical databases, Medline, Scopus, and Cochrane. So as we know that during nighttime there is a normal dip of 10 to 20% in normotensives and untreated hypertensive patients, a dipping phenomena followed by a rapid and gradual increase during night hours. In these studies being reviewed, patients were classified according to the rate of fall of systolic BP during 24 hours according to 4 categories: extreme dippers who dropped more than 20%, dippers between 10 to 20%, and non-dippers drop less than 10% and more than 0%, and reverse dippers or risers drop less than 10%. Now, deviating from standard dipping patterns is associated with an increased risk of acute ischemic stroke and highlights the value of chronotherapy, whereas no significant difference is observed in stroke prognosis. The extreme dipping pattern is associated with occurrence of ischemic stroke, either due to undertreatment or due to subsequent morning hypertensive spike, whereas aggressive antihypertensive treatment seems to be significantly responsible. Interestingly, the occurrence of microbleeds in ischemic stroke territory has been strongly associated with reverse dipping pattern. So conclusion, overnight BP variation is an independent and robust predictor of cardiovascular risk, including acute ischemic stroke. Nocturnal BP may constitute a therapeutic target for prevention of acute ischemic stroke. However, the available data on the effect of antihypertensive drugs and implementation of chronotherapy with pre-sleep medication are conflicting in terms of improving cardiovascular risk. Therefore, at present, current guidelines for the treatment of BP do not recommend the aforementioned therapeutic approach as the best treatment in day-to-day clinical practice. More extensive and targeted studies are needed in the future to confirm the potential benefits of the application of chronotherapy in the prevention of acute ischemic stroke. Thank you very much. That was all that I had to give you from day 2 of European Society of Hypertension meet this year, and hope you have had some learning points from each of these presentations. So goodbye, and till we meet again for the next ESH conference.